because we will give a good information. I was just unable to do it today. Sorry about it. Anyhow, today we will just a very short topic, but you will get a likely to get a short note on this short note and some very practical important points. So we'll talk on sickle cell arthritis. How do you manage it in a total hip replacement? So it is a very difficult condition actually, and that's why all of us should know what is really a sickle, and we do have sickle cell in our country. So sickle cell hemoglobinopathy is called sickle cell anemia, hemoglobin SC disease, hemoglobin S beta delta thalassemia also is included, and hemoglobin S beta thalassemia. So these are the four conditions we are included in the hemoglobinopathy of a sickle cell. So the sickle cell disease affects approximately 7,000 people in US. Predominantly, most of them are African Americans, 1 in 500 births, and in that group of race. Is also present in Portuguese, Spanish, French, a lot of Scandinavian countries, and we do have in our own country. Actually, we got experience from Middle East patients because we used to get a lot of Middle East patients, and we learned actually out of from them, and then we realized we do have sickle cell in our country. What is that zone in the sickle cell in our country? If you look at this belt, it's a very classical belt. Classical belt, part of Gujarat here, part of Madhya Pradesh, part of Maharashtra is Nagpur. That's why we got a lot of experience in the Nagpur. Dr. Babulkar has also written quite well on sickle cell actually. He's got a monogram on sickle cell itself. And part of the Orissa is very small part is there. Chhattisgarh also, and this is a belt which is there. Andhra belt is also there. So we don't know why exactly this is the belt of this belt like this. And it is, we don't see at all anywhere here. And there's a small pocket coming here down in Tamil Nadu, part of Kerala, very small, but it's not a very dense. It is a very dense sickle cell here. So I think you must know this is a belt, and if you just draw this diagram, probably the examiner knows that you are read quite a bit of sickle cell. So what is the prevalence of avascular necrosis in this group of patients? 8.9 is the highest in sickle cell thalassemia, and 54% are bilateral sickle cell. So this is a roughly percentage. About 10% of the sickle cell will land in AVN, and they will land in a orthoplasty. So what is the natural history of the sickle cell as far as, because it is slightly different than AVN what we are getting into alcoholic and cortisone and other. This is a totally different entity. Stage 1 and stage 2 progresses to 87% within 5 years of diagnosis. So once they have a sickle cell, you can consider almost 90% are going to get into progressive arthritic stage. Stage 4. Stage 0 asymptomatic hips, 84%. Asymptomatic, 84% progress to symptomatic head collapse and femoral head. And average, roughly, it takes about 14 years, roughly average, to develop that. So it's a very asymptomatic, this is a very slow progression of the AVN takes place. 15 years follow-up, 80% of the hips become painful, decreased mobility, length disturbances. This is a big problem of this because this start with the children, and that's why limb length problem in the sickle cell in children is very much, and abnormal gait where the disease is in the childhood because it starts in childhood, and with that 15 years the limb length problem disturbance is very high, and 80% of these patients are going to be painful. So again I'm repeating, stage 1 2 progresses 90%. 0 asymptomatic stage, 84% will progress, but it's a very slow process, and they might take average about 14 years. So this pathophysiology is very straightforward. Last time we discussed AVN, what happens exactly. This is one of the, that also time I had discussed was the third part was hemoglobinopathy, because sludging, the blood circulation gets stopped because of the sludging. Localized sludging of sickle cell in the marrow synovials, leading to necrosis and necrosis of the bone and osteocyte. So depth of the osteocyte is very important because there is a hypoxia of this, because there is no circulation possible next forward. So they get a lot of edema. So pressure increases, intra-osseous pressure increases. So they get almost like a rebound phenomena, and they develop lack of oxygenation, leading to edema, leading to osteocyte death. It can progress. One subsequent repair may lead to healing in a younger patient. If children are very young, they develop a sickle cell crisis and they come out, some of them, because they have a lot of power of repair. So these patients become asymptomatic totally, and they can have a normal thing possible. Increased intraepithelial pressure causes bone resorption, which ultimately leads to subchondral fracture, collapse, and secondary. But once the subchondral fracture occurs, nothing can stop. Nothing can stop. So before that, if they have an insult, the sickle cell patient, some of the younger patients are likely to revert back. That is one important finding. Whereas in avian, alcohol and cortisone induced, there is no question. There is no way. Okay, this is one other important factor which we are missing actually. Other organ system involvement. As an orthopedic surgeon, we just look at the bone and nothing else. Even we don't want to look at the soft tissues. But here, this disease is drastic. This is very aggressive sometimes. So they have retinopathy, they have chronic renal disease, they have cerebrovascular accident, pulmonary disease, congestive cardiac failure, because they are cardiac failure, deep vein thrombosis, splenic infarct is one of the most common thing which occurs, and tell you why it is important, splenic infarct. And salmonella osteomyelitis is again extremely common, and this will be, they usually ask in the exam, this is the, why do you get a salmonella, so we'll come to that. Why the prediction there. Why increase risk of infection in this group of patients? There is a multifactorial. So infection rate in sickle cell, arthroplasty, or any surgical procedure is very high. It is multifactorial. Most important first factor is a spleen. That's why the spleens get infarcted. These patients they are not good because they have lose one reticuloendothelial system. So they don't have the immune mechanism. And that is the reason they have a high rate of infection. Asplenidia, abnormal hemoglobin system, abnormal intraosseous perfusion. So the antibiotics are not reaching. Even our immune system is not reaching. Chronic skin ulcers, and that remains permanent, and that's why they get metastatic infection from these chronic skin ulcers. Sloughing of intestinal mucosa. This is one of the important things which happens, which we don't realize actually. These patients do develop a crisis and also develop an intestinal mucosa sloughing, and they develop a secondary infection because our gut has got a full bacteria, tons of bacteria in the gut, and then they develop an infection. They develop late hematogenesis. This is very important, which we were not aware. So that is the reason. This is a multifactorial to have an increased rate of infection in sickle cell. If you mention this, it is a very, very important slide as far as you are concerned. Asplenicia, abnormal immune system, and abnormal intraosseous perfusion, chronic ulcer, and sludging of intestinal mucosa leading to bacteremia and late hematogenous infection. What is the life expectancy? Initially, life expectancy were very poor, but thanks to our hematologists in this country, they have actually increased their life expectancy quite well. When I was a houseman, sickle cell means is almost like 10 to 15 years. Most of the people will die. But today, male has 42 and female has 48 average expectancy. Sickle cell anemia and SS 50% cross fifth decade, and sickle cell SC, males 60 and female 68. That is a roughly life expectancy of these patients, this patient. So, but average is about between 40 to 50. That you have to keep in mind. What is imaging? We do it for sickle cell. Plain radiograph, no question. I will discuss with you. For IP, lateral frog, other thing views are. But MRI is gold standard as far as sickle cell are concerned. Because if you look at this MRI, this is hip. You see the geographic infarcts. You see the knee. Once you see this type of knee and this type of hip, you can just blindly say this is Dr. Sickle Cell. These are pathognomonic sign of MRI. So you will get everywhere infarcts, and they are all geographic infarct, and they are very, very large infarcts. They are not like a small infarct like which you get in avian. So the whole head gets involved. And in our idiopathic and alcohol segment get involved. Here whole head gets involved because it's a generalized disease. So MRI is gold standard, just keep in mind. X-ray pictures are again very clear. All these patients, we are, whatever the avian is, segment, there's no segmental avian. They get a diffuse avian. And second important, trabeculations. They are gross trabeculation. Third important thing is a double canal. You see there's a cortex here. There's another small radiolucent line and one more cortex. So this is called double canal. This is pathognomonic sign of sickle cell. This also happens in osteomyelitis, but you know it. So these are the two conditions it tackles with the double canal phenomena. And once you see with the avians, see with the gross trabeculation, see with the double canal, this is pathognomonic sign of a sickle cell. You can also see what happens in these patients. In avian, you will get only segmental area. But in sickle cell, you will get a telltale sign somewhere. You look at this infarcts here, look at the lesion here. Also, he's got in the femur. Look at this femur here also. So this is a very distinct feature of a sickle cell. So it is not get isolated with a small segment. So it is a generalized get a segment. So that's the way we pick up sickle cells. What is the management of early disease management? Can you reduce the incidence of avian? Yes, there is a possibility. When the patients are young, when they come into the crisis, yes, you can do hydration, rest, crutches, pain management, and must prevent painful crisis. This is one important information. And if you can prevent the crisis of this patient, they're likely that they will not go into avian or into multiple infarcts. Not a question of avian, multiple infarcts in the other part of the bone. So once they are minor symptoms, they should approach hematologist, and this is the way they are managed. Most important, hydration, rest, crutches, pain management. Preoperative workup for this patient. We do need a special attention for preoperative. You should not take lightly. Patient comes on the day in the evening. Patient is posted for some surgery of a sickle cell. Please do not do that, because you require hematologist with a side by you. You require a lot of investigation for this patient. Rate of complication, I'm going to show you, it is just you cannot imagine. Even they are very, very high rate of complication. So very important, 50% surgical complication in hip surgery. Look at this. We work on 1% complication of our hip surgery. Today, this sickle cell has 50%. How can you operate them just like that, light-minded? So we need a lot of investigation. We need a lot of backup. We need to console the patients. We need a proper workup of this patient. Very important information I'm giving you. So hemoglobin level should be minimum 10. And this is another important factor. S hemoglobin should be below 30%. You will have to drop it down. Most patients coming for AV and other thing are 50%, 70%. If you operate them in 70% of hemoglobin S, these patients are going to die, literally. So you have to bring them down, and only you can bring them down by multiple transfusion, So, but if you are too aggressive in multiple, its transfusion-related complications will be very high. So very important to bring hemoglobin S below 30%, and then operate. And another important thing, it is not only bringing on the day one. You have to maintain till the patient is out of the suture till suture removal. It is not only on day 1 or day 2, 3. There, at least for 2 to 3 weeks, you have to maintain this level by repeated investigations and multiple transfusions. So another important information to you: bring hemoglobin S below 30% before surgery. Maintain it for 2 to 3 weeks. Then your complication rate drops down. Another important information: spinal and general anesthesia has got high rate of complication. So spinal anesthesia, epidural anesthesia. Even small children, it is possible to operate them lower limb by a caudal or a spinal caudal anesthesia and other thing. It is possible. We got good anesthetists in this country now. Good oxygenation, good hydration. It is not the oxygenation at the intraoperative in the operation theater only anesthetists will look after. They required at least 24 to 48 hours in the ward and all other things. And they all require is you will have to give them a spirometer also so that continuous oxygenation is maintained for them. Hydration. This is most important. Most of the time what happens, day of the surgery is over, next day morning the patient is shifted to the ward, whatever is, and we don't write any IV fluid, we don't write anything because these patients are likely to take less IV fluids. So you have to maintain till they are in the hospital 2, 3 days, 4 days, you continue them IV for 1.5 liter, some fluid has to be given to them. So that is very important, hydration. And with that hydration, you will not get into crisis. Prophylactic antibiotic, we need to use a higher antibiotic for these patients. It will not work with generation 1. You might have to use generation 2 or generation 3 antibiotic for these patients. DVT prophylaxis, full prophylaxis needed. Mechanical, chemical. Post-op pain management is very also important because that triggering effect should not be there. Otherwise, they will go into crisis again. Avoid hypothermia. Operation theater, do not bring it down too much. That day you might be sweating little, doesn't matter. So the temperature normally we keep around around 20, 22. We have to keep it on the slightly on the higher side for these patients. And we try to get the warmers for the patients. So the upper part of the chest also can be put the warmer and keep the patient warm enough. Another important thing, all IV fluids and blood transfusion should be warm and given at a room temperature. Please do not start straight away from the from the blood bank, start immediately because the patient has got hypotension, this, that, all sorts of things, and you will transfuse them and they will have a problem. So hypothermia is another important factor. We need to avoid as far as possible at every point, not only in the theater, outside the theater also. Caution with CRP. This actually I was also not knowing because of my little bit reading. I came to know about this. This is very important, again, important information I'm giving you. Non-sickle cell patients, it is always less than 10 according to the lab. All the sickle cell patients will have a higher. So if there is CRP high, that means you will say that in fact there is some infection and you will not operate. So this is the normal value of sickle cell patients. Almost between 20 to 30 is a normal value. So don't get worried that this is 30 CRP, I'm not going to operate. You will start hunting, doing MRI, this, investigation, blood culture. Please don't do that. Look at the patient properly, examine the preparer, ask hematologist, and this CRP may be normal to that patient. And when patient is in crisis, look at this, CRP goes up. This is one more very important information I am passing on. Very important, which I was not aware. So surgical procedure, decompression, yes. Even though this is not a segmental, but I think we should, these are very young patients actually. They are in 20s and 30s. I think one should give a little chance because one should give a chance. We know it is generalized disease. So decompression stage 1 and stage 2 can be considered. A lot of controversial report as far as this is concerned. I've gone through a lot of literature regarding this. So, but still, my personal feeling is I think we should give them a chance because it's a generalized disease. You can do a decompression stage 1 and stage 2. Once the fracture occurs, then I think you should give away. So, total replacement in sickles, very high rate of complication. One of the report I'm going to share with you. One of the Middle East, there's a lot of work on the Middle East. One of the surgeon had 100% complication. So that is, forget about it. But in general, the complication rate is high. Okay. Excessive bleeding, hematoma, wound drainage, sickle cell crisis, difficulty in opening the canal. There's a mechanical block because all canal is infected. and it is very difficult to open these canals. It is not easy job. I was struggling for one of the patient. It is quite problematic. So you need high-speed burr, you need intramedullary reamer, you need a sharp drills, all that you require. So it's very difficult to open the canal, which I'll show you how it is to be opened. Femoral perforation and fracture is very known because these bones do not have elasticity. So when you start broaching this bone after reaming, they don't expand. So they fracture. So that is very important. So you have to be absolutely gradual, and most of the time you can't do preoperative planning because there is already infarcted bone. You can't put a templating. So you'll have to, a lot of judgment you have to use. Femoral perforation is very high. Infection rate 16 to 20%. Look at this. So sometimes that is the reason most of the patient of sickles, I don't want to do totally, unless they are really problematic, then only I will ask them to get a surgery done. Mechanical loosening. Also with these patients after even surgery of total lips, they don't do well on a long term. Look at this, 38% at 5 years, 50% failure at 10 years, mechanical loosening, aseptic loosening. Cemented component much more high. Why? Because cemented component, because you need reaming. Once you ream the canal, there is no micro interlock. The cementing does not get into grade 1 cementing, grade 2 cementing, and that's why the rate of failures are high. So another important thing, cemented stems will not do well. The reason is because you do not have a cancellous available bone. So we don't have micro interlock, and that's why it will fail. Uncemented, now new stems are much better prognosis. There are multi-center studies, 27 patients, 70% survival, 70 only % survival at 4 to 5 years, where osteolysis is still problem with this patient because they are very young. Now, this is a very busy slide, but as a DNB student, you need to go know that the result. If you look at the result just roughly, all these patients, everybody has a very, very small number of patients, 20, 30, 20, 30. Only this is the one article, 2008, he had a 312 patients. This is the largest data of 2018. So in this group, complication rate, look at this, 25%. So infection rate, look at that, 8%, 12%, roughly 15 to 20% infection rate. Look at this complication here, fractures, so much of, and even the follow-up is just about 8 to 10 years. So looking at the all data across the world, you should all keep in mind that 50% these are going to fail at about 10 years, less than 10 years time. Uncemented may be slightly better. Cemented stems and cemented implants have a very high rate of failure. Okay, this is another very important information for you. This is the paper which I was telling, that this patient coming from Bahrain, and he had almost like 100. He operated 41 patients, he had 43 complications. He had everything possible. He had bleeding, he had perforation, he had crisis and whatnot. So the patients are very, very high risk patients, which is one of the important information. This is one of my patients. You see a double canal here. So it was impossible to open. So you require image intensifier. Otherwise, you will go into false track. Once you get into false track, you will not be able to come out. It's very, very difficult. So after cutting your neck, put a drill guide, look at the AP, lateral, look at everything. And only just putting this is not enough, because you will not be able to put implant. You have to put a cannulated guide wire and start reaming from 6 or 7 millimeter. And sometimes they are not available. You will not be able to open these canals. Very, very difficult. And it takes a long time. That's why the complication rate again goes off infection and other things. So this is that patient which follow. This is one of my patients who I operated about a couple of years, 7 or 8 years back, and everything was fine. One day this fellow landed with this discharging sinus. So he developed metastatic infection. And look at this femur. So we have to do extensive surgery for this man. did a complete decompression and put a muscle pedicle inside, and that fellow healed up, healed up. This is another patient of mine, which I was in Bombay. I operated maybe about 15 years back for this very young boy, sickle. And look at this osteolysis he developed. Massive osteolysis, where? Because it's just a 10 to 15 years follow-up. Look at the whole bone is washed out proximally. So he could not, he couldn't, it was not possible for him from Mumbai to come here because of a poor patient. Luckily, one of my colleague operated free of cost in one of the general hospital. What he did, he changed the liner on both the side, and during the surgery, he had a trochanteric fracture. There's osteolysis. Once there is osteolysis in the proximal, which I told you, chances of fracture are very high. Sometimes we use a prophylactic wiring for these patients, and he fractured here a little bit and just put one of the tension band device. And luckily, yes, this hip has survived. So what is the treatment of cure or a cure for this? I think only answer for these patients are going to be bone marrow transplant. And that work is fairly going on well with the sickle cells. Risk and has a lot of complication. Some promising treatment for hydroxyurea, blood transfusion, pain relief, etc. Young children under 5 years, they take usually penicillin twice to prevent the pneumonia and other thing, which a medical problem. So take home message for sickle cell arthritis or sickle cell. For minor disability, avoid surgical intervention, which I told you very clearly. Don't be aggressive for this patient for surgery. If they can tolerate, just continue. The surgical rate complications are extremely high. Involve hematologists on day one, please. Very important message, important information. Hemoglobin must be 10 before surgery, and bring the hemoglobin S to below 30%, maintain till 2 to 3 weeks till the sutures are removed. Pre-op worker, good imaging, spinal epidural anesthesia, intra-op image facility, intramedullary reamers must be available. Avoid hypothermia, hypotension, and good oxygen intra and post-op both. And prophylactic antibiotic may continue for longer. Normally in hip replacement, we usually give only 48 hours, maximum 72 hours. But these patients will require till their sutures are out. They are fairly immunocompromised. Maintain hemoglobin till wound heals up. Hydration, pain management, IV fluid, blood transfusion with room temperature. That will be the important message for all of you. Thank you.